Standardization. Cos'è questo? Ah, questo qua che deve andare via.
Il computer
Schmidt poteva partire.
sì, aveva chiesto di passare.
Ok. Cominciamo?
Ah sì, dal telefono.
Okay. Good morning, everybody. I hope that the last night gala dinner was to your liking and that you didn't exaggerate too much with the good wine which accompanied the meal. Another busy day awaits us, and I hope we'll have some interesting result. I would now like to invite two chairmen, Martin Grabenvoger and Malak Shestra. Malak? Okay, please. And for the chairman is today, and start the program with the debate organized from Dr. Eleftherides. Please.
Good morning. Through the journal Aorta, we will be holding regular debates to be published in the journal on important topics in aortic disease. And we'd like to take a 30,000-foot view of certain issues in our specialty and have experts like we have today discuss these different issues. For this morning, we've chosen the topic of aortic valve repair and framed it around the question, can the results of aortic valve repair equal the results of a biologic aortic valve replacement? So we have all these experts here today, and we'd like to look at a number of specific questions around this topic. And I've asked Dr. Mohammed Bashir from Liverpool to, in 3 minutes, present the results of his meta-analysis of the papers written on this topic. Dr. Bashir?
Thank you, Dr. Alfredis. Good morning, Chairman, members of the panels, colleagues. Thanks. It's a privilege to be asked by Dr. Alfredis to present the results of our meta-analysis, and I would like to thank also Dr. Di Bartolomeo for giving us the opportunity. So what we've done is we've looked at systematically at the literature, at all the published literature that looked into aortic valve repair, and we've derived our own meta-analysis from that. Just to, because it's a brief session, so I'm going to only point out the in-hospital mortality results, the reoperation according to etiology, based on bicuspid aortic valve, cusp prolapse, aortic root aneurysm, and I'm just going to set a brief conclusion towards that. So what we looked at is 8,761 paper that talked about aortic valve repair. They were pulled from 3 main electronic databases, PubMed, Ovid, and the Cochrane. And out of these 8,761, we pulled out 24 papers potentially that include, that matches our inclusion and exclusion criteria. All papers reported in-hospital mortality. As you can see, they're all listed down. And the weighted average for the in-hospital mortality was 1.46 after aortic valve repair. We looked at the reoperation, and this slide shows reoperation following following valve bicuspid aortic valve repair. And these are the papers that mainly looked at, and the results are plotted. And as you can see, the weight average for reoperation following bicuspid aortic valve repair is 10.2. And average follow-up was 4.1 years. This slide shows reoperation following cusp prolapse. And these are the main 3 papers that reported that. Weighted average for reoperation was 3.83, and average follow-up was 3.7. This slide shows also reoperation following for aortic valve repair following aneurysm repair. Weighted average 4.25%, and average follow-up 3.2 years. So what we conclude? We concluded that aortic valve repair may be a useful option for selected patients, and there is a lack of uniformity in data and compelling evidence. We obviously encourage an international multi-center study that will look at comparing aortic valve repair and aortic valve replacement. Thank you. Back to you, Dr. Afshars.
Thank you, Mohammed. And now I'd like to frame the discussion for the panelists around a number of particular questions. And I started out with a quotation that several repair techniques have been described to correct aortic valve dysfunction, but in contrast to mitral repair, few of them have become gold standard techniques because of the unpredictability of their results. Now, this quotation comes from probably the greatest valve surgeon in history, Dr. Alain Carpentier. And in particular, he points out that there is a small amount of tissue with a smaller potential surface area of coaptation, and that this prejudices negatively aortic valve repair compared to mitral or tricuspid repair. So I'd like to start by asking the panelists to comment on this. In particular, do you feel that aortic valve repair is in the same league as mitral valve repair? And do you share Dr. Carpentier's thoughts about the lack of adequate substrate of tissue for repair?
Yeah, I mean, I think if we look to the aortic valve as a leaflet only, I think Carpentier is right. But nowadays, I think we should look to the aortic valve, not only leaflet, but also functional unit. So the goal of any valve repair, as Carpentier says, is really the matching between the orifice and the quantity of tissue we have. So if we have less tissue, we reduce the annulus. If we have, or we add the tissue, and so the goal is really to restore this matching between the orifice and the quantity of tissue. So I cannot agree with Carpentier when he says that this is limiting factor for us. We should really always find the equilibrium between the quantity of tissue and the orifice. That's my opinion.
Thank you, Dr. El-Khoury. And I think everyone in the room has tremendous respect for the techniques that you have developed and taught. Do we have other comments from the panel on this question?
I personally think that what Carpentier was meaning that the quality of tissue is different, of course, in the mitral and in the aortic valve. Being the tissue of the aortic valve much more thin, so it is difficult to deal with. And besides the leaflet and the annulus, there are components present in both. I think in the mitral there are decorded. There is a component we don't have in the aortic. That's why make things probably more difficult. And also regarding the quality of tissue, I think there is also difference in bicuspid and tricuspid, also in terms of tissue. That's why sometimes to repair a bicuspid is easier than to repair a tricuspid valve, because of not only the geometry difficulty, but also for the quality of tissue.
Yes, the answer for the question is yes, because I'm sure Carpentier is right. And then you can now see that easier to repair bicuspid valve. And then trying to create the tricuspid into bicuspid valve. And the quality of tissue, amount of tissue in between aortic and mitral valve, making aortic valve repair have a more narrow margin of error. And then we saw that people like Professor El-Khoury and Professor Schaefer, we are grateful for your advancement and the progression for our community, but I have to agree with Professor Carpentier that there is a margin of errors for us, too much for every surgeon like us to start repairing it.
Can I have only small, short answer? I mean, it is difficult. It's a little bit confusing to say that bicuspid valve repair is easier bicuspid valve repair is easier to be repaired than the tricuspid. I mean, the problem is, I agree that at the level of the leaflet, yes, maybe because we have two lines of quotations to control. But the big problem in bicuspid is not only the leaflet, it's really the root, the annulus. So for me, it's much more difficult to have a good valve repair in bicuspid aortic valve than in tricuspid aortic valve. It's really more, for me, it is more difficult. It is not only a problem of the leaflet. We should take care also of the VAJ, the ventricular aortic junction, which is really very difficult to treat in bicuspid aortic valve.
Joe, another brief comment, and then we'll move on to some more questions.
You know, I think the substrate issue is, to answer the question, there is a difference between leaflet surface area availability and substrate. So I think you can answer the substrate issue with one really simple question, or simple observation. How many times in your practice have you ever seen a Marfan's patient need an aortic valve replacement in the absence of an aneurysm? And the answer is zero, never. So the substrate, and even the worst patient of all, which is the Marfan's patient, has nothing to do with these repairs, okay? So if you can take a Marfan's patient with their crummy substrate and you can put it into a normal geometric aortic root, that valve will last forever, because you never see an isolated aortic valve replacement in the absence of an aneurysm in a Marfan's patient. So I don't think the substrate issue has any issue whatsoever.
If I may make another comment regarding what Justice Jabrin said, it is true that when you're speaking about bicuspid and tricuspid, it seems you're speaking about two entities. But while tricuspid is more or less always looking the same, bicuspid have a lot of variability. So it's true that in some cases, like type 0, can be very easy to repair. So the spectrum on bicuspid is so variable that's probably can make any comment different depending on what the presentation of the bicuspid is. The bicuspid, let's say, or unicuspid we saw yesterday is not the same as the one.
Thank you. And let's move on to some other particular questions. This is some very recently published data about the longevity of biological valves. And as we can see, in patients over 70, there is no reoperation whatsoever. Patients 60 to 70, it's very good. And even patients less than 60 at 10 years have a greater than 90% freedom from reoperation. So let me ask the panel, how do you feel about biological valves in the aortic position? And are you concerned that the poorer performance in the younger people is an Achilles heel of the biological valve?
I think biological valve in most of our hands is reliable, predictable. And then if you look at the recent result published from this paper that you kind of alluded to, as well as compared to Professor El-Khoury and Professor Schaefer's and the valve repair results, and 90% or around 3 years the freedom from structural degeneration in the valve repair. And I think biological valve is performed better in 3 years. And that's one thing. And then in aortic position, in most of our hand, it is reliable. That's two. But saying though, if you're the second question, do we feel that it's a result in the young patients Achilles heel? Well, we can't forget there are plenty of young patients all over the world with mechanical aortic valve being perfectly managed with anticoagulation and then living a normal life. And so we shouldn't forget about this population either.
Thank you, Dr. Wu. Any other comments about biological valves? Yes.
Can I just say, obviously the younger age is the highest risk factor there is for premature structural valve deterioration for the biological valves. And yeah, the results are reproducible for an aortic valve replacement. But I think the one important message is, you know, Carpentier said that the unpredictability of results makes aortic valve repair not widespread. But another big problem is not so much the unpredictability from my point of view, it's the small numbers of these patients. And if you take into account in the United States, for example, the average cardiac surgeon does 10 aortic valve replacements per year. You can't expect that person to be an expert in aortic valve repair. So I would argue if you have a young patient with aortic insufficiency and pliable cusps, I stress that again, pliable cusps, those should be referred to a aortic valve repair specialist. End of discussion from my point of view.
Dr. El-Khoury?
Yeah, I mean, the main issue is the selection of patients. Young patients with normal leaflet is an excellent candidate for aortic valve repair. We should really make the difference, like on the mitral valve, if you have a leaflet problem or annulus problem. The annulus problem for me is the aneurysm, the dilation of the aortic root, STJ, ABJ. That's really, we should look to this functional aortic annulus exactly the same way as for the mitral, the annulus. So if you are talking about pathology of the annulus at the aortic side with normal leaflet, the result will be perfect at 10 years. I mean, the valve will function for forever. Now, if you look at the cusp pathology, leaflet pathology, prolapse, calcification, thickening, those are different. So if you have talk only about the prolapse, normal leaflet, I think you repair the prolapse, you achieve a good result, immediate good result. This valve also will last for a long time. So I think we should really insist now, because this is evolving surgery, the aortic valve repair, we should insist more and more on the selection of patients for aortic valve repair. In young patients with normal leaflet or dilated aortic root, that's really the key in my opinion.
Thank you. And let's move on to a couple other questions. Now, these are the very recently published results from Mayo, from Dr. Schaff, applying all of the aortic valve repair techniques. And they show a 20% reoperation rate at 10 years. So I'd like to ask you, the panel, do you think that we really can match the durability of biological valves in the aortic position? And how do you feel about a 20% reoperation rate, especially if it's a young patient? How do you feel about this data?
Well, I think this data is wrong, okay? This is data from way back when. This is the bicuspid, especially bicuspid and even three-cusp aortic valve repair techniques really have only matured in the last decade. And the results now are just so much better than looking at that old commissural operation that they did in Mayo for all those years. So I actually don't believe this data, and I think it's irrelevant. It's kind of like textbook. It's already gone in history. And so I think if you look at the newest data, though, about the newest repair techniques, both for bicuspid and for three-cusp aortic valves, especially when you use the reimplantation technique, the reoperation rates are much lower than what you're seeing here. And also, going back to that last slide, you know, the average age of these aortic valve reparative series is in the 40s, and tissue valves are not very good for that age group. So, how do I feel about this data? I think it's irrelevant.
I think if we consider the last slides you showed there was, I think, 10% reoperation at 10 years for biological valve below the age of 60. And just recently there have been published a review on all results of valve repair, bicuspid or tricuspid. And the average of 5 years was 10% among all the most relevant studies. So now I think, even though in the last year many advances have been done, at 5 years is the same as the biological prosthesis at 10 years. The problem is that I don't know, you should be looking at the, I would say,
in Italian.
Yeah. I mean, so if we can reach the 10 years with the valve repair, is much better than with bioprosthesis, because after 10 years the bioprosthesis at that age the curve is steep.
Can you show that? Can you show that slide again? Rogero is making an excellent point. You don't see the logarithmic fall off, which you always see with biological valves. The only question with biological valves is where is the tipping point? Where is the logarithmic fall off when all of the patients start coming back? You know, for the Toronto valve, it was earlier than for the Perimount, for example. And if exactly what he said, if you've got a repaired valve that's still functioning 10 years, it's going to function for a very long time. And you also don't have endocarditis,
yes,
other
problem
complications.
is that when you get the reoperation is better if you, after valve repair, after failed bioprosthesis at 10 years. That's, I think, the main point, because after 10 years, the bioprosthesis really, below the age of 60, really the curve is very steep. While for valve repair is probably not the same steep, the same, let's say, the steepness of the curve is different, but and the result of the operation is probably better because the operation is easier with less complication with the standard redo for bioprosthesis.
The other thing about these young patients is that if you take, you know, the concept of prosthesis-patient mismatch, or PPM, if you take these young patients with high cardiac outputs, and even if you put a standard valve in them, whether it's mechanical or tissue, you'd be surprised at the amount of mild to moderate PPM that you see in these patients. And that may have a long-term, and you almost never see that in any valvular reparative series. So it's more than just, you know, durability and everything else. There's a lot of, there's hemodynamics, there's all kinds of, and freedom from endocarditis and all sorts of things that are probably superior in the reparative group.
These are all very important points. Let me move on to a couple more questions.
Can I have, yeah, sorry. Yeah.
Basically, all the experts have made major changes in their techniques of repair within the last 10 years, Joe, the point that you were making, that some of the older data may be outmoded. What are the implications for the patients treated earlier, and how do we know that our current techniques will be durable? Can I have some comments on that, please?
Can I start with, we're just mixing up the different patient groups here. And I have no problem with the valve reimplantation in the aortic reimplantation David procedure, because we all know that. And that's a different group of patients compared to where you do perform the leaflet repair. And so if you perform the good reimplantation technique and David procedure, I have no doubt that that patient, the valve function will last and the operation durable. And this is something that we should try to teach people and they perform to high standard. But for the leaflet repair over the last decade, there's so many modification leaflet techniques and annuloplasty techniques, and then the evolving technology with a variable result in even in the best hands, we can still see the 3 years result with freedom bronch structure dysfunction is about 90%. And somebody like my average hand probably would be worse. So at this time in this kind of aortic valve repair era, I don't think I can support the leaflet repair on its own would be kind of joke.
I agree. I mean, I think if you go back even to the last slide, I don't know about what patient they are talking. That's really the problem now in aortic valve repair and all the published articles. I think some years ago I wrote a paper about the comparison between mitral and aortic. If we want to progress in our communications, in our aortic valve work, I think we should know about what we are talking. And if you look to the sparing surgery, for me that's annulus problem. So we will talk only about annulus problem, like the mitral. If you will talk about the leaflet, that's another problem. So I think you look at the mitral prolapse P2, we know what is that. But what is the equivalent on the aortic side? We should look maybe for the prolapse of the case of yesterday. So we should really know about what we are talking. That's the big problem now in aortic valve repair. We should, let's say, we should have a homogeneous the same language when we are talking about the aortic valve repair. I am sorry, when you see the 20% recurrence of aortic of reoperation, I don't know, aneurysm, rheumatic, endocarditis, calcific, bicuspid, tricuspid, we don't know. So I think in order to progress, we should now separate. We should talk about sparing surgery, about tricuspid, about prolapse, about rheumatic. So in that way, we can compare our results and really found the excellent candidate for repair regarding the most appropriate surgical techniques, the most appropriate immediate result. I mean, we know that on the mitral. In order to progress on the aortic side, we should do the same work. Really focus on the pathology, selection of patients, and see about what we are talking.
And
That's my problem.
Let me ask one more question before I ask each panelist for their summary. If there is mild or moderate aortic insufficiency after aortic valve repair, are you concerned about that? Are you concerned it may be dangerous like we're seeing for AI after TAVI?
Short answer, yes.
Yeah, because actually in our number after valve sparing operation, the most important finding variable that was the aortic insufficiency immediately after operation, meaning if you accept 2+ AI that is not central, that will have a very bad result in the long term, even at 5
But
or 8 years.
it's not dangerous, though. It doesn't affect survival. The TAVI patients, it affects survival because the aortic insufficiency is acute. They have the hypertrophied ventricles that have been seeing stenosis for the last 20 years, and all of a sudden now it sees AI. And it's a very dangerous situation for those patients. These patients, they've had AI for many, many years already. So mild to moderate AI, it's not going to end up in them dying, but what it translates into is that the patient is going to be coming back earlier for a reoperation. So that's why and that gets back to your previous point about how do you know the new things that we're doing, that they're going to be durable. Well, the best way is to make sure that you have as little AI as possible at the end of the operation, and then you're more confident that the repair is going to be durable no matter how you got there. But also, it's also learning from our colleagues. Even Schaefer's, who is the world's biggest supporter of the Yakub operation, even he admits, because of his colleagues have basically convinced him that any annulus that's more than 27 millimeters, you can't do a David operation. Yakub, you have to do a David operation. Or we've learned from Jabrin's group that if there's some residual prolapse, even if the valve is competent, that has a negative outcome for the durability. So you should try to get rid of that prolapse. So it's a constant learning evolution that we're learning from each other.
I mean, I agree totally. The big problem is to see what residual regurgitation we have. If we have an eccentric, you should have a zero tolerance for that. If you have the eccentric jet. Now, if you have central jet with a good cooptation, good configuration of the leaflet, I think this one is not so harmful for the future. So, again, we have our echocardiographers, we have our cardiologists in the OR, our anesthesiologists. They should do an excellent echo. I mean, the echo should be excellent in the OR. And if you have any eccentric jet, we should not accept it. That's really the message. Yeah.
One thing to add, though, I think over the years, in the name of advancements, we accept more and more imperfect operations. And then we started with TAVI, we accept a kind of mild paravalvular leak is acceptable. And then with the mitral repair, people started accepting mild, sometimes moderate mitral leakage at the end of the procedure. Patient go out with that and then say there will be no long-term kind of problem. And now I don't want us to go down the line saying that, okay, aortic valve repair is good, and so many other right side effects can be avoided, but we shouldn't be accepting a moderate aortic regurgitation going out of theater. And then I'm sure if patient have a moderate aortic regurgitation at the end of procedure, within the next 3 years, 5 years, and there's no doubt there's an effect of aortic regurgitation to LV function.
So these are all very valuable comments. Let me, in concluding, just go down the panel and ask you to give me a yes or no answer about whether you feel biologic valve repair can equal the results of a biological prosthetic aortic valve. Do you want to start, Dr. Wu, and go down the panel? You can give me, please, a yes or no answer and a brief concluding comment.
Since we haven't got this at the moment to divide into category, in general for valve repair, and I would say if it's just purely for valve repair, I would say valve repair can't be equal to the result of biological valve at the moment.
What was the answer?
No.
No.
Selection of patients, the most appropriate surgical techniques to be applied to the patients, and I'm convinced that aortic valve repair is even better than bioprosthesis?
I will say no, depending on the age. Let's say at the age of 65, 70, I will say biological prosthesis cannot be equaled by repair, probably. I mean, it's not worth it. But in the younger patient population, it's worth to try also because it's getting close to that point, and the redo will be much better.
I say yes if the cusps are pliable and if it's done in a referral center.
I think anybody who has pure AI, no calcification, bicuspid aortic, tricuspid aortic valve repair is not only equal but superior at all age groups compared to a biological prosthesis. I remember 20 years ago, 15 years ago, when you said, "Oh, we're not going to do a mitral valve repair in a 75-year-old." We're just, that's history. That's history. So.
One last word. We should also talk about the survival of those patients, in young patients. The survival when we have a prosthesis is much less than aortic valve repair also. I mean, the survival also is we forgot to talk about that. When you have a prosthesis, I mean, 10 years after, a lot of patients disappear, whatever is the material.
Yeah, but I think in survival, the condition of the patient are different. That's why it influences survival, not the technique, but the general condition of the patient. So.
No. In the young patients, the survival is better.
There's a 10% survival gap in biological valve patients compared to the normal age-matched population that nobody can explain. There's 10% of patients that are dead 10 years later, and nobody knows why. And that doesn't seem to be the case for aortic valve repair or for Ross operation.
May I ask a few questions to the audience?
Please.
Right, in the present era, with the present all these techniques, you've seen that the great surgeons operated on the valve repair yesterday in 2 cases. Right. So first of all, I'd like to know how many of you performed regular aortic valve repair? Could you show the hand, please? About maybe 10, 12? Okay.
Some years ago,
and next thing I'd like to ask, how many of you perform more than 20 aortic valve repair a year? About maybe 10, okay. How many of you perform more than 20 of bioprosthetic valve replacement? More than 20 a year? Everybody, okay. And when you are having this valve replaced, if you are 50, if you have a kind of valve disease with some degree of calcification, valve thickening, like yesterday's first case, if it's your valve, would you like your valve to be replaced or repaired? How many want to repair? Could you put your hand up?
First case?
Nobody.
One day.
In the pediatric case.
How many wants a valve replacement? I think I rest my case because in those days we all want to be alive.
I agree that the first cases was not for the for 50 years. No.
Well, we got some animation from the panel here in this debate, and I want to thank all the panelists for sharing their expertise with us. Thank you.